Okay, we're going to review Chapter 16, Nursing Care During Obstetric Procedures. First thing we'll discuss is an amniotomy. An amniotomy is usually performed in conjunction with induction or augmentation of labor. Remember when I mentioned in Skills Lab when we break the water, in layman's term, an amniotomy, with that water gone, we have the weight of the baby on top of the cervix, so it helps in augmenting labor and promoting dilation. What are the risks involved with it? Well, there are three main risks that we worry about. Of course, if we're going to have a gush of water, one of the things we worry about is the cord coming with that gush of water when the physician breaks the water. One of the ways we help prevent that, of course, is that when we set up to do this, we want to make sure that fetus is at least at a zero station. The next risk that we have is infection. Once we break that water, again, we've taken away that protection. And at this time, we would, of course, do temperatures a lot more often. We would do them at least every 2 hours. And we would be very judicious about how often we do vag exams. Of course, always with sterile gloves. And we want to make sure once we have broken that water that that baby is delivered within 24 hours. That's the window that we look at. And that's why, like I said in Skills Lab, if we're interviewing a woman who is coming in with broken water, we're going to time it from the time she estimates that she thought her water has broken and look at hopefully having that delivery within 24 hours. Next risk would be abruptio placentae. When you have a lot of fluid pressing up against the uterus, there's pressure there, so it's pushing out. So if you have a sudden gush and you're taking away that pressure that's pushing against the placenta and up against the uterus, you risk it almost collapsing in a way from taking away that pressure, almost like a hot air balloon. When you take away the air that keeps a hot air balloon rounded, how it suddenly just collapses, that is one of the risks that could potentially happen. This could either be a partial separation or potentially it could be a full. How is the technique done? It is done with a device. It's called a plastic membrane perforator. It looks like a knitting needle in a way. And by sterile technique, the healthcare provider will first check dilation and effacement because the needle has to fit in through the cervical opening. And next, the station of the fetus. We want to make sure that it's at zero. And then what he will do is rip the bag to allow the water to go out. Now, what are our nursing considerations as a nurse? What is it that we're going to do during this procedure? Well, first thing we're going to do is we need that baseline fetal heart rate. Remember what we said? A minimum for a baseline is 20 minutes. So you're hoping to get 20, 30 minutes worth of strip before you even have this procedure done. Then with assisting the amniotomy, we got to make sure we have very clean pads, several of them under the woman's buttocks. We want to make sure a towel is available. We're going to set her up in the proper procedure. We'll have all the supplies ready for the physician, and actually what we'll do is we'll partially open the package so he'll be able to remove the perforator when he does the technique. What is it that we're worried about after doing an amniotomy? Well, our priority intervention is checking that fetal heart rate for a full minute. We have to check again. There could be not just maybe a possible cord prolapse that's obvious, but it could be a or up at the very top. So it may not be obvious in possibly unless you do a vag exam, but we would pick up on it on the fetal heart monitor. So remember what we know about to say that we have a prolapse cord. We're looking for those severe variable decels. A lot of times with cord compression, with those severe decels, we will have a baseline fetal heart rate of under 100. The other thing we're going to look at, other considerations in care, is we're going to assess the amniotic fluid. We're looking for the amount. Was it a large amount? We're looking for color. It's supposed to be clear. Okay, that's the color we're hoping to have. But if we have a yellow color to it, and we see that we may have an odor to it, then we're worried about infection. Odor tends to tell us that there's infection. The other color we're worried about is possibly green, because that would mean that we have meconium release, and a fetus will usually do that because they're under some type of stress. So if we have a yellow color that's cloudy in appearance, cloudiness again, we link that to infection, and also with an odor, then we're concerned that we're possibly having an infection. So in our assessment, we're going to watch that fetal heart rate very carefully. We're going to do frequent temp sten, and also the physician may decide to treat it at the time depending on how bad the assessment is. So now the woman's temp, we're going to, again, we'll assess it a lot more frequently. And what we're going to do is we will report anything over 100.4. But remember what I said in the past, like in the skills lab, we will usually, the core temperature of a woman will go up before you can actually pick it up on a thermometer. So a lot of times you will see the fetus heart rate from that core temp will become tachycardic before you actually see it in mom's assessment. So that's why we're going to watch that fetal heart rate very closely. We're also going to provide comfort once it's broken, and we may still continue to have leakage. We don't want bacterial growth. We're going to change those pads frequently and provide for the mother's comfort. And there we see in the picture how he would use that hook, go in, grab the bag, and rip the bag, the sac. So let's kind of review what we just talked about. First question I'm going to ask are, what are the 3 risks associated with an amniotomy? And the 3 risks we went over is, first, the prolapsed umbilical cord. Second, infection. So once we break that water, there are increased risks for developing infection. And the third one was abruptio placentae. Next question, why is the fetal heart rate assessed before and after the membranes rupture? Well, of course, anytime we do any type of procedure, provide any medication to mother, do any type of change, we always assess the fetal heart rate. Well, the reason we do it before is because we want to make sure before we do a potential change in the environment for the fetus that they do have a normal rate and pattern in that baseline. Now, the reason we assess it after the procedures, we're looking to see if we have possible umbilical cord compression. Okay, next is, what is the significance of green amniotic fluid? Well, I did mention it. It could be meconium that is passed from the fetal intestines, and a fetus may do that under stress. Sometimes we may see it in post-term fetuses, or if there's any type of placental insufficiency. And remember what we're worried about placental insufficiency. We may also see that in hypoxic conditions such as late decelerations. And the last question related to this area, what maternal and fetal signs are associated with chorioamnitis? Well, we kind of tie that into infection. So, of course, the obvious one will be, for mom, the elevated maternal temperature. And what we may see as a first sign is the fetal tachycardia, again, for mom's core temperature. And also, if they are running a tachycardic and mom may be running a fever, the other area that we're going to look at, other than physiologic, is how the amniotic fluid looks. If it's sort of cloudy or yellowish in appearance and has a foul or strong odor, then that is suspicious of chorioamnitis. Now let's look at induction and augmentation of labor. Okay, in that, induction is where we put a woman into labor. Augmentation means we are helping the labor to progress. We're augmenting it along. We would do an induction or augmentations for several reasons. One of the reasons could be that the environment, it might be hostile to the fetal well-being, such as intrauterine fetal growth retardation or placental insufficiency can cause intrauterine fetal growth restrictions. If there was a spontaneous rupture of membrane, so her water broke at home, she's not going into labor. We have that 24-hour window, so of course we want to put her into labor. If there's a post-term pregnancy, because that placenta is only supposed to have a certain lifespan, so it starts degrading, and that means we don't develop enough amniotic fluid, and that puts in an environment that's not good for the fetus. So if they're past 42 weeks, they may induce the mother. If there's hypertension involved, as you've learned in prior chapters, the only cure for severe preeclampsia is delivery of the fetus. And even then, they're still at risk for seizures afterwards for 24 hours. If they have abruptio placentae, that would be just a small or partial abruption, because if she has a full abruption, that would be an emergency C-section. That is an immediate delivery. We cannot wait on that. And also, if we have any maternal conditions that are being aggravated by pregnancy, such as renal disease, she has some type of heart disease, pulmonary disease, and last, it would be if there's a fetal death. What they would do is put her into labor so she could deliver the fetus that's no longer living. And that's important because once that baby starts breaking down in those proteins, she's at risk for developing DIC. However, it isn't recommended that we use induction just for convenience. There really should be a reason. Other factors or risk factors they might look at to induce is if a woman lives very far away and she has a history of fast deliveries. They may do that just so there's not a risk of her delivering before she gets to the hospital once she gets close to term. So what are some of the contraindications we got to worry about? Well, the ones where we would not even, usually if you cannot have a vaginal delivery, we're not going to augment. And the things that we look at that could possibly be an automatic C-section, one of them is placenta previa. Remember, that is the hemorrhaging. So we're not going to add to that bleeding situation. If there's any problems with the fetal umbilical cord, such as vasa previa, if we come across having an immediate umbilical cord prolapse, we cannot wait. That would be an emergency C-section. Or anything where there's a fetal malpresentation. Remember we went over the 4 Ps, passage, power, passenger, and psyche. Well, that passenger, the fetus, if they're in a presentation that cannot be delivered, such as transverse shoulder presentation, or in some way it might be hazardous, then they'll just do a C-section. They won't even bother augmenting. And there's several other reasons, and they're all listed in your book. So what are the risks involved with this? Now remember, we are causing these hypertonic, we have the potential to develop a hypertonic uterine activity from the use of Pitocin or any of our prostaglandins. So those are the risks. We're worried about developing the high uterine activity, and with that, we risk having a uterine rupture, which is, of course, an emergency. The other thing we're worried about is one of the potential side effects of using oxytocin, and why we're careful on how we mix it, why we use an isotonic fluid with it, is that we risk developing maternal water intoxication. And that's if it was mixed with a hypotonic solution, and we would do a rapid amount of oxytocin. So we do a very slow, gradual raise of it, and we put it in an isotonic solution to avoid that potential problem maternal water intoxication. And by the way, one of the signs of that, because that is where they're holding water, we're diluting the intravascular fluids. One of the signs we would see is decreased urine output, and if we're diluting our intravascular fluids, we would also dilute the electrolytes. So we would see, of course, hyponatremia, signs related to hyponatremia. So those are some of the risks that we may see. In technique, of course, it depends on what we're going to do. It would depend on if we're going to do a prostaglandin gel or a vaginal insert, or are we going to use oxytocin, because all three of them are sort of related to using in the use of induction or augmentation. And remember the last one we went over, amniotomy. It's a mechanical procedure, but that is also a way to augment labor. The big thing we do, we went over it in the lab, and determining whether induction is indicated is that Bishop score. We look at dilation, effacement, fetal station, cervical consistency, and cervical position. Even though a doctor may not write down Bishop's score within his notes, he does check all those areas before he would start someone on oxytocin. Now, one of the ways, if they want to use oxytocin, what they might do first if they don't have a high score to start an induction with oxytocin, they will try to ripen the cervix, and they would do that with those prostaglandins. That would be your Cervidil or Prepidil. We went over, those are natural prostaglandins. They're very expensive. A lot of times what you'll see them use is misoprostol, which is a GI drug. It's category X. And the name brand, of course, is Cytotec. It's a tablet. They take the actual tablet that someone would take. They will usually split that in half and just put it up by the cervix. So make sure in your review, you review on page 364 the slight differences between using a gel and an insert. And one of the big things you see is that there's an interval before you would give more of that medication or start oxytocin. Because if you look at the vaginal insert of Cervidil, you have to wait 30 to 60 minutes after removal of the insert, where compared to Cytotec, you have to wait at least 4 hours after the last dose. So those are some of the things you got to look at when you use these drugs. The type of drug you use to do a cervical ripening will dictate some of your procedures or protocols, and one of the big ones you got to look at is how long you have to wait before you would start oxytocin. Now, when you use these gels, even though it's being put within the vaginal area, you can still put someone into hypertonic uterine stimulation. So we still monitor them for uterine activity. Make sure that they're having their resting phase and their contractions are not lasting long. Now on oxytocin administration, we also know that as Pitocin. Again, as I said earlier, we will put it in an isotonic solution. We give it as a secondary piggyback just to make sure if something happens, we can stop it very quickly, and then flush with our primary bag. And it's put as close as possible to the venipuncture site, so the proximal port. And we start it slowly. Of course, we're going to have that baseline fetal strip before we start. And then what you're going to do is you're going to look at every 20 minutes, 15, 20 minutes, you're going to look at that strip before you raise it again. So you got to go back and look at your past strip before you start raising up the level. What we look at doing is trying to get her into the active phase. So we'll raise that dose. Once she's having good regular contractions, then we'll stay there and we can actually start taking it off of her. We can start reducing the dose. I'm not going to go too much over cervical induction. I really don't see it used that much. It's when they try to do, when the cervix is not favorable, instead of using the gel, they would just use a little bit of oxytocin over a period of time. But now what we see, the trend is just using the gel. Now make sure that you review on page 366 your drug guide. This puts in a nutshell a lot of all the nursing considerations you need to do and how to monitor it. Remember, oxytocin can also be used for postpartum, also for uterine atony, to help firm up a bulgy uterus. Now remember, the labor pattern we're watching for and where we're going to be concerned, and we're going to shut off the Pitocin, is if they run contractions longer than 120 seconds or regularly 90 to 120 seconds or more, and the contractions are occurring less than 2 minutes apart, or that resting phase is less than 30 seconds. Remember, we have to have it, and also if we do not have an internal monitor, we got to do that by palpation. And then we're also going to see how the fetus responds to those contractions also. We're going to look for non-reassuring patterns in the fetal heart rate. So then, basically, what we're looking for in what I just said is the fetal response and the maternal response. We're going to be alert for any changes in the fetal heart rate. Remember about non-reassuring. We don't want tachycardia. We don't want fetal bradycardia, which is less than 110. We're going to look for those late D cells and decreased variability. If we see that, or we see those contraction patterns I was talking about lasting very long, being hyperstimulated, that means having more than 3 and 5 minutes, because that means they're having them less than 2 minutes apart, or we don't have our resting phase, what we're going to do is immediately stop the oxytocin infusion. Then we're going to, because it's secondary, we're going to increase our primary infusion. We're going to keep her on her side to increase placental blood flow. We're going to give 100% oxygen by face mask, and for the woman it's 8 to 10 liters. And then we're going to reassess, and we're also going to notify the physician. Now, if it's related to uterine activity and it's not going to, and it still remains hyper despite the fact that we stopped the drug, we may give something that is a tocolytic. And the two big drugs we use is either terbutaline. Terbutaline can be given by IV, sub-Q. It's also an oral form. Women who are in preterm labor will go home on that. Or the other one is magnesium sulfate. So then for mother's response, we're going to monitor her blood pressure and her pulse frequently. Again, we're going to monitor her uterine contraction. And then she's going to have significant pain because it really increases the contractions. So we're going to watch her pain management. After birth, because we are getting a lot stronger contractions on this Pitocin, oxytocin, it puts her at risk from wearing out that uterus throughout labor on this drug. She's at risk for postpartum hemorrhage. So after she delivers, we're going to be careful about monitoring for uterine atony. And she's probably going to receive it for that reason also after delivery to help continue to keep the uterus contracted. Now, a very important point I want to mention about resuming Pitocin. If for any reason you do stop that Pitocin, you have a hypertonic contraction, lasted more than 2 minutes, or and you shut it off. You reassess, it starts to calm down. Maybe 40 minutes later, the physician says, you know, everything looks great. The fetus was okay through all this because you stopped it from the contraction. Let's resume. Well, if you started at 2 milliunits and you were at 6 when you shut it off, you have to go back down to 2. You do not go back to where you left off. You're going to start that process from the beginning, start it at 2, get your 20 minute of strip, watch her, raise it again, look at 20 minutes strip, then raise it again. So that is important to remember when you're going to resume Pitocin. Okay, so let's do a quick review. Again, we're going to check your reading. What precautions are taken to enhance the safety of oxytocin for the mother and the fetus? Well, the 5 precautions, first of all, we went over about we're going to dilute oxytocin in an isotonic solution to decrease the risk of water intoxication. We do it by piggyback, so that way we can stop it if we have to. And we put it as close as we can to the proximal port. Next thing is we start slowly. That's a safety measure. We increase the rate gradually. And we monitor the uterine contractions. We make sure we're getting our resting phase and they're not hyperstimulating, because that will impact on the fetus eventually, or we can put the woman at risk for uterine rupture. And then also we're going to monitor the fetal heart rate. It's considered, once they're on Pitocin, a high risk assessment. Remember, on your care path we have low risk, high risk. If they're on oxytocin, they are considered high risk for assessment, so that's like every 15 minutes. How may oxytocin administration differ if labor is being augmented rather than induced? So what's the difference when we use it in that sense? Well, labor may be augmented if it stops or contractions begin to become ineffective. That's what augmentation is. So they usually need less of a drug to kind of kick-start them into a regular labor. And also because her uterus is more sensitive to the effects if she's already started labor. Remember when I discussed in lab, for oxytocin to work, the oxytocin receptors must be opened. That's why you can't put someone who's only halfway through their pregnancy on oxytocin and then think you can just put them in labor. They got to be near labor because those receptors are receptive to the oxytocin. So if she's already going or starting labor but they're weak, she has more receptors to attract the drug than if she wasn't in labor and you were going to try to do it by an induction of just using Pitocin. However, that's one of the reasons also we do the Bishop score, because if she's dilating in effacement, then we know there are receptors that will attract the drug. And with her having a higher Bishop score, even if we were doing an induction, we can look at her being somewhat successful, but if she's already in labor, there's even more receptors open, and so she needs less of a drug. Next, what signs may indicate a non-reassuring fetal response to oxytocin stimulation? Well, let's look at from lab. What are those big non-reassuring signs we say over and over? We got the tachycardia, the bradycardia, the late decels, and the decreased fetal heart rate variability. Now, the other thing that's non-reassuring would be, of course, severe variable decels, but in this picture she may not have her water broken. So that's why it's not mentioned in this situation. Of course, if we break the water, that's one of the things we would have to worry about. What are the signs of hypertonic uterine activity? Well, that would be, of course, when we don't have that rest, and that would be if we're touching the uterus when it's resting and it's less than 30 seconds, or contractions are lasting more than a couple minutes. And the other thing we're worried about in hypertonic uterine activity is the strength of them. Now, in measuring it on the strip, what we don't want is our units, our MV units on our strip being more than 400. But remember, you can only measure that if she has an actual IUPC, intrauterine pressure catheter, which measures strength of contractions put in, and that can only be put in if her water's broken and she's dilated enough, because that is a lot bigger than, in fact, your fetal scalp monitor. So by then we do it by palpation, and we're looking to see how strong they are. Next question, how can induction of labor with oxytocin contribute to postpartum hemorrhage? Well, if you're listening through this, what I had said that it puts a lot of stress on the uterus. We are really kicking that uterus into contractions then if we went into natural labor. So it's tired. We have a very fatigued uterus. So when you're fatigued, of course, you don't want to move. So that contraction, that uterus does not want to contract on postpartum. So by it being able to have uterine atony, then we risk her going into hemorrhage. So Pitocin is a risk factor for postpartum hemorrhage. Okay, let's go on. Version. Version is where we actually take the fetus externally. It could be internal or external, but external is from the outside. If we have a breech baby, we turn it around to put it head first. So basically, we're trying to optimize a fetal position. And the reason this may be done is because if we do a successful version, it allows her to have a vaginal birth instead of a C-section birth. So this baby could be maybe side to side with a shoulder presentation, could be oblique, and they're going to try to put it head first. Now, internal version is if we have maybe one born, because you got to have access to get in there. And so one would come out, and then the physician may go in and manually from the inside invert the fetus. So if it's a vaginal delivery for twins, that way he's optimizing the position for the delivery. But nowadays, usually with multiple births, they just do a C-section. So what are the contraindications for doing an external version? Well, if she's someone that doesn't plan on having a vaginal birth, that's one reason we wouldn't do it. Another would be if she had any type of uterine malformation limiting the room. If she had a previous C birth with a vertical, which is cesarean birth, with a vertical uterine incision. Now, if she's a vertical incision, chances are she's not a candidate anyway for a VBAC, vaginal birth after C-section, so of course there's no reason to do it. Now, fetal conditions that might contradict the use of version. First of all, again, placenta previa. They are not going to be a vaginal birth. If there's multiple gestations, because there may not be room, the other concern is if she doesn't have enough amniotic fluid, because if that cord can't remain buoyant within its environment, then we risk wrapping that cord around part of the fetal body. And also the other concern we have is if they have utero-placental insufficiency. Usually you will pick up that up on a baseline strip before you would do the procedure, then of course we would not. So what are the risks involved with this? Well, there are several for mom and baby. One of the things you got to worry about, of course, is that if mom is RH negative, this procedure could potentially risk mixing of the or sensitization of the fetal blood. So then, of course, they'd be a RhoGAM candidate if they were to do this procedure. We may risk the umbilical cord becoming tangling up, and also we risk putting her into labor by manipulating her. Now, in the technique, what's key with this is you can't do it too late and you can't do it too early. If you do it too early, the fetus is small enough to flip back to where it was. So the optimum presentation or the optimal time to fix this abnormal presentation is around 37 weeks. So it'll be anywhere from 37 to usually the range they may say is 37 to 40, but most will do it around 37 to 38 weeks. Another reason for wanting to do it at that time is if you do set her in labor from doing this, she's close enough that we don't have the significant effects of having a preterm delivery. So one of the things we're going to do when we do this is we got to relax that uterus, because if you're going to be touching and manipulating it, of course we're not doing it, this is a physician that's doing it or a midwife, you have to relax it. So they're going to give her a tocolytic. Again, remember the two that we usually use would be MAG or terbutaline, but because we're not in an urgent situation and when they do this, they're going to use terbutaline. They will usually give it by sub-Q, but of course we're going to make sure we have an IV line in case of emergencies put in. And then next thing we're going to do is cover her for pain. A lot of times they may use an epidural or spinal for it. They have to do an ultrasound because they have to know exactly what position this fetus is in. And also during the procedure, monitor what's going on, keep an eye on the fetal heart rate, and see what position you put the baby in. So we're monitoring it by ultrasound, and we're also monitoring the fetal strip. Well, that would be in your baseline because you can actually use your ultrasound to monitor the heart rate during the procedure. Now, what do we worry about? Well, we're going to worry about the drug. We got to explain the potential side effects of the drug. Remember, with terbutaline, one of the side effects is we can have some fetal tachycardia. It does stimulate. Mom may complain about feeling a little anxious when she takes it. She may have some tachycardia herself. We also got to make sure all the consents are signed. And we're going to have all our baseline vital signs. Again, fetal heart rate patterns, at least 20 minutes. We're going to assist with the ultrasound. And afterwards, we're going to observe for at least 1 hour. We're going to check her mom's vital signs. We're going to check the fetal heart rate. Remember, what we're hoping to have is the best measure of fetal well-being, and that's hopefully seeing an A cell before they leave. We're also going to monitor them for pain after the procedure. Our warning signs, of course, is if we're going to have regular contractions, which means she may have gone into labor, if she leaks some water because somehow the bag was broken during the procedure, or if we see a non-reassuring strip. So let's review on this. Why is observing the fetal heart rate important before, during, and after an external version? Well, that's because we want to make sure we don't have a non-reassuring pattern before doing this, and it also tells us how well they did afterwards. We can monitor it again by the ultrasound. For the fetal heart rate also, we could do a baseline strip before we do the procedure, and then even during we can monitor by the Doppler that is used in outpatient often. Also, it will tell us if the cord became entangled or is compressed, because that's another thing we'll pick up on our post-procedure fetal monitoring. Why should the uterine activity also be monitored afterwards? Well, we want to make sure that we haven't put her into labor. Manipulating the uterus can be irritable. And also the other thing we're worried about is any risk of abruptio placentae, even mild, as a result of this condition. So before we send her home, we want to make sure the fetus tolerated it, didn't have the cord wrapped up, and mom didn't have a change in status. She's still intact. She didn't start going into labor as a result. Oh, and there we go with we can see in our photo how he's taking the fetus and moving it. We have our IV. Usually it is, again, even though they give an IV line, the tocolytic drug itself can be given sub-Q. That's usually how they do it, but they can do it by an IV line. But we want that IV line in case of emergencies. They don't show it here, but you would have either a ultrasound or a Doppler right there watching the fetus during the procedure. Okay, we did that. Let's go to operative vaginal birth. Well, that's when we're going to use those forceps or vacuum extraction. And a lot of times that's used to aid with the descent and rotation of the fetus. Sometimes they may use that if the fetus is in an occiput posterior position. In fact, in that position, women will commonly complain of back pain with it. And also we use it a lot if a woman has been on an epidural because she doesn't have that sensation of pushing. So she'll have this prolonged pushing episode. If we see the fetus isn't tolerating it, suddenly they may use the forceps. Another reason they may use it, if suddenly during the pushing phase we see non-reassuring patterns. Now, I remember years ago they used to have something called a high forceps delivery, which means they went way up there and pulled the fetus down, and we really don't see that anymore. They just do a low forceps delivery, which means the fetus has started moving down the canal before they attach a vacuum or a forceps and pull the fetus out. Contraindications to this is if she's going to have a C-section, there's no reason we would even consider this type of birthing. The big risk with this is, first of all, in mom, would be her getting lacerations or hematomas. If you've seen those vacuums or if you've seen the forceps, I had them out during Skills Up. They're very heavy and they're metal. So by using them up around soft tissue, we risk maybe damaging the tissue, causing bleeding within the tissue. And for hematoma, remember, the number one sign is severe perineal pain. That's what the mother will complain of. Laceration would be a steady drip of blood. So if a woman has a pad that she's soaking less than an hour in postpartum, but you notice her uterus is fine and contracted, well, you might consider looking at, well, did she have a forceps delivery? Because maybe it's a laceration that is filling up the pad, and that is usually where you don't have the clots in it. You really just see this bright red blood on the pad. Now, by putting these forceps on around a fetal head, what we may see as problems for the fetus or risk is that they can get ecchymosis and facial or scalp lacerations or abrasions, and the one we worry about is facial nerve injury. And think about it, facial nerve injury, if we have it on one side, one of the big signs we're going to see is a droop, maybe a droop in the mouth or the eye. That will kind of tell us that there's been some nerve damage when we do our newborn assessment. Another thing we worry about is cephalohematoma. If we have heavy bleeding through the scalp or underneath the scalp tissue, and also the other problem is intracranial hemorrhage, that puts them also at risk for jaundice, because if you're breaking a lot of blood cells, which is what happens in bruising, then that red blood cells contain bilirubin, so you're releasing a lot of bilirubin in circulation. So any type of heavy bleeding or bruising, such as a cephalohematoma. The other risk we may have as a secondary issue would be the development of jaundice. Now, when we use the vacuum extractor, which is at the top of the head, so it's not going around the face, so we may not see so much the face damage, the one-sided hematoma or cephalohematoma. And basically, you can tell a cephalohematoma from scalp edema, because a cephalohematoma stays on one side of the suture lines, so it doesn't travel over the scalp. When it comes to just having a sucadenum is what we call it, caput meaning head, it's a big watery almost blister on the head of the newborn, and that can come again from maybe possibly, they call it chignon if you use a vacuum, but you can get that just from the stress of a maternal delivery. Any type of stress, of course, if you have an injury, you have edema with it, but it's not really blood. It's just almost like edema. But the thing is, it does cross the suture lines, and it's almost like touching a waterbed sometimes when you feel the top of the fetal scalp. And the fetus will, over several days, absorb that fluid. Okay. So again, you might see that in a chignon, which is scalp edema. You might see it, the other word is used, caput, if it's a vaginal delivery without the use of any type of instrument, and that is not a problem. But if it's a cephalohematoma, and actually they can even pick that up on x-rays if it after several days, because it just kind of sits in there. But it doesn't cross the suture lines, and they're at risk again for when it comes to any type of bruising, and release of blood, jaundice. So in our technique, preparing the woman, of course, if we got to make sure she has adequate anesthesia. They can do a pudendal block if they have to. They'll use a forceps or vacuum extractor, and we'll see pictures in a little bit. The other concern is a lot of times to make room for these blades or this vacuum, they might do an episiotomy. So that's another procedure added to it that we got to worry about if a woman's going to have this. She may also have that. And basically they pump it, they attach to the scalp, and they descend the fetal head and body. So one of the things we got to do is worrying about her being stressed. For nursing, one of our big assessments afterward is assessing for vaginal wall laceration. So that would be by seeing brighter red than normal lochia bleeding, and it's a steady drip. We're going to check if she has any type of hematoma. So she'll complain of severe relenting pain, and we'll see some discoloration of the labia and perineum area if she has that. And the fetus, we're going to check for any type of reddening or bruising of the scalp. And also we want to worry that he doesn't have any scalp lacerations as a result of these procedures, because that puts him at increased risk for infections. Okay, so there we go. There's our forceps. At the top, we also have what we call a Piper forceps. That's B up in this photo. That is used for a breech delivery. They'll go, they deliver the body and they go up and they reach in around to help assist the head out. And this is the vacuum we were talking about. There's the chignon, which is the little bit of edema at the top. It crosses the suture lines that go across here, across the head. And that's how you know it's not a cephalohematoma. And that's from the pressure of the cup. And they vacuum it up, add suction, and then help descend the fetus. Okay. Check our reading. So let's kind of see if there's anything we've got to worry about or review. And one of the things we're going to find out is what are the similarities in the use of forceps and vacuum extractors, and what are the differences? Well, they're both used for the same reason, and that's to provide traction traction to the fetal scalp to assist with the delivery. And some of the differences is that forceps can cause fetal injuries such as facial bruising and nerve injury. Of course, the vacuum extractor can create that artificial caput called a chignon, but usually that won't usually be too much of a problem. And the other thing we worry about with if you use a vacuum, they have 3 attempts that they call a pop-off, and if that doesn't work, then they don't then go to a forceps delivery. What they'll usually do maybe then is a C-section. But that's one of the things that they don't want to do. So then, why should the nurse add a urinary catheter to the instrument table if a vacuum extractor or forceps-assisted delivery is needed? Well, what did we learn from epidurals, right? We learned that sometimes they don't have a sensation of bladder, and the reason we got to keep checking it is because it impedes the descent of the fetus. Well, if we're going to manipulate the fetus coming down, we have to make sure that we don't have a full bladder, because we want as much room as possible, and there's also the risk of bladder injury by putting instruments going up. So that's one of the reasons why we want to make sure we have that available. So next, let's ask, a woman has a forceps birth with a median episiotomy. Well, we didn't go over episiotomies yet, so I won't discuss that. And what injury is suggested by an asymmetric facial appearance when an infant cries. And I discussed that earlier where we're looking for droops, and droops would mean that they're asymmetric, and that may be that they have some type of facial nerve injury. And that would be, of course, not by the vacuum, which is only on the scalp, but by a forceps delivery. Okay, I want to go over episiotomies. Even though your book discusses episiotomies, they don't discuss the different degrees, so we're going to go over that. The first degree is the smallest, and that's when we just go through the vaginal mucosa. Our second is the most common, and actually they document the degrees in the chart regarding episiotomies. Also, we do by degrees if it's a tear. Episiotomy is a surgical incision done by the physician, and a tear means it was unplanned and we have a rip. Third degree is involves the vaginal mucosa, submucosa tissues, and also part of the sphincter muscle, which would mean the anus. And our fourth degree is the most severe type. We are going into the lining of the rectum. Now, what you have to remember with this, with care, is that for third and fourth degree, we do not give after they've had that, because we don't want to risk any type of further damage during the healing process. Suppositories, because we may give suppositories to other women because of constipation. There's certain pain meds we can give by suppository, but we do not give suppositories to women who have third or fourth degrees episiotomies or tears. So that's what you have to remember. Okay, so we do it for a couple reasons. It can be if we have to make room for a body part, like such as a fetal shoulder, if we're having a forceps-assisted delivery, sometimes because of the way the fetus presents, if they're occiput posterior, then they have trouble with that rotation. And sometimes they may do it for the birth of a small preterm fetus, so they have reduced pressure on the head. So what are the risks? Well, infection is the main risk. That's why you learned in skills, if they had episiotomy, we do RITA, and that's to check if they're having signs of infection. The other concern we'll worry about is pain. So we got to assess or provide relief for pain. And with a episiotomy, basically what they do, there's two different types in the technique, and we'll see that in a minute in a photo. And for nursing considerations, one of the things we worry about in the postpartum phase is that we teach them how to do perineum care. It's using the bottle, padding from front to back. We also talk to them about, that's why we also provide ice, again, to decrease the risk of edema after delivery to the perineum area. We put a lot of ice, decrease the edema to the area and the risk of bruising from the procedure. And then that's usually for at least 12 hours, and then we could potentially go to heat afterwards. And this is a photo of it. Now, the tears can go the same way, and the reason why they tend to do episiotomies is that they feel it's better to do an episiotomy and have control of how the cut's done than to risk having a tear that could, tear into the anus. And also tears are jagged, so it takes a little bit more work sometimes to provide stitching. So the advantage of doing a median or midline with that, we have minimal blood loss. There's little scarring. However, the disadvantage is that there's always the risk, if there wasn't enough room, that it would, during the delivery process, rip into the anal sphincter. And there's only a limited opening for that reason. Now, if you do the medial-lateral out to the side, which is the other photo, there is more blood loss, there's more risk of scarring, but there's little risk that it will extend into the anus. Cesarean births, they are done because someone is not a candidate for a vaginal birth. A lot of times they do it now for multiple gestations. They do it if we have an urgent situation such as a prolapsed cord, or there's a problem according to the fetal monitor related to fetal oxygen or acid-base balances, and we have to do a urgent delivery. They may also doing if the fetus is too large for mom to deliver vaginally, or also if she had a classic C-section before, we're going to do it again. She has to have a low transverse scar in order to attempt a VBAC. So that's why some women, if they have a classic C-section, and we'll go over that soon, then they will always be a C-section. The problem with it is afterwards, because you will never get 100% strength of that uterus again. If they have repeated C-sections, you keep weakening the uterus. So there's always a problem when women are having more than 3 births by C-section, because that uterus is almost paper thin and it's at risk for rupture. Once you cut into skin or muscle, you never get your 100% strength again, so you're continuing to weaken the area. So what are the contradictions? Really, there's not that many, because the only alternative is the fact that they may is a vaginal birth. So usually it's a surgery, but there's really not any contraindications to it. Just maybe the type of anesthesia might be an issue, things like that. Now, the other thing we look at with a C-section is what we call, again, as I said earlier, a VBAC. And that is when a woman attempts a vaginal delivery after she had a C-section. Usually they want them to wait quite a bit between that, so that it allows the old scar tissue to heal if they were to attempt that. And when we see the photos, we'll discuss about what type of C-section is appropriate to maybe attempt a VBAC. So what are the risks involved? Any type of surgery has its risks, and that includes infection, includes hemorrhage. They could have urinary tract trauma from it. Because they're in bed a little longer, they're at risk for thromboembolism. We're careful about listening for bowel sounds returning, because they're at risk for paralytic ileus, and any type of complications related to anesthesia. Now, for the infant, the big thing we see is that they're at risk for what we call transient tachypnea of the newborn. It's called TTN. And in theory, what it is that they feel when a fetus comes down the canal, that whole process of coming down the canal, squeezing the lungs through the canal, then opening up to take the first breath, that stress of labor and stress of labor delivery helps to absorb some of the amniotic fluid in the lungs. Well, if you don't go through that stress of labor, then what they feel is that they're at risk of this transient tachypnea of the newborn, because they have delayed absorption of the lung fluid. So they have a little bit more fluid, so they're at risk for having a little bit of respiratory distress. Usually with supportive therapy goes away after 24 hours. It is different from what we call respiratory distress syndrome. So that is one of the things we worry about in a C-section birth in regard to the fetus. Also, because they're not going through the stress of the delivery, there may be persistent pulmonary hypertension. That's related to it going over to the fetal circulation. The stress of labor helps with that also. And then also, there's the risk by cutting in that there could be laceration, bruising, or fractures related to the delivery. Our other concern, of course, is also that we don't do the C-section too early, because we're at risk then with lung immaturity of the newborn. So what are we going to do as nurses? Well, we're going to provide emotional support. We're going to do all our teaching in regard to what we're going to do for preparation of a C-section, like all cesarean births. And all surgeries is we get our baseline lab data. The big one is our CBC, because we got to know our H&H. They may do clotting studies. We also got to make sure we have a type and match. Next thing would be is helping to set up, if she hasn't already been on it, is her epidural or her spinal, depending on what type we're going to do. If it's in an urgent situation, she will be under general anesthesia. We also will give our GI drugs, such as Pepcid and Vicitra, to help reduce gastric acidity. And like any surgery, we'll do our timeout. We will get our baseline strip before she has her C-section. And they may provide prophylactic antibiotics and then antibiotics afterwards related to the surgical procedure. And of course, an indwelling catheter will be put in. They prep the abdomen and, of course, move her over to the table. They do not run a fetal strip during the procedure. They get a baseline and then they go ahead and do the C-section. Next thing we worry about is, again, any type of teaching we have to do. Remember, it's based on what's the situation for the C-section. When it comes that this is an emergent situation, we got to be short and sweet. We're also going to explain, if we have time, about all the potential pre-op procedures, what's going to happen. Tell her about how she's going to be in bed afterwards, that she's going to have a recovery time. She won't be able to eat right away. Also, we need to tell her what's going to happen about the epidural. She's going to have loose feeling to her lower legs. Because at this sense, usually if a woman knows she's going into a C-section, she's worried, she's anxious about what's going to happen to her baby, especially if it's an urgent situation. We also got to provide safety. We got to make sure we know the last time she ate and drank, especially if we're going to do general anesthesia. Because it is a risk there. It's a high risk for aspiration under general anesthesia for pregnant women. And then we have to be careful with moving the woman across or transfer her to the table, operating table. We got to make sure her bony prominences are cushioned and make sure we have our safety strap. And in post-op, we do just like we always do in a post-anesthesia care unit. We assess frequently. We make sure we check her vital signs. We make sure her respirations are okay. She gets return of motion, level of consciousness. And then we also do, which is what we do for any of our post-surgical patients, that type of assessment. But then in addition to that, we got to worry about our postpartum assessment, which includes checking the lochia, her uterine firmness. We also got to worry about pain relief and bonding. So if she was under general, we want to make sure when she gets up, somehow she gets to see her newborn. That's another thing we have to worry about. O2 sats is another big thing that, of course, we're going to monitor. Now again, let me get to the VBAC. To be a candidate for VBAC, you cannot have the same condition that you had your prior cesarean for. That's one of the criteria. So if I had a cesarean related to malpositioning, then if I have another malpositioned baby, I'm not a candidate for a VBAC. So that's one of the criteria that goes with that. The other thing is she has to have had she has to have a low transverse cesarean. Let's see if I have that next. Here we go. So we have our vertical and we have what we call our bikini, or low transverse. And one of the things you have to remember is it's not how the cesarean scar that's on the abdomen dictates what type of cesarean she has. What I mean by that is the physician may cut into her abdomen this way because maybe she had a scar or rash or something going on at the time, but then actually cut into the uterus in this direction. So you have to find out what her uterine incision was, not what you just happened to see as a scar on the abdomen, to determine if she is a candidate for a VBAC. And there's some more right there. There's our low transverse. There's less adhesions, less blood loss. It's easier to repair. And this is the least likely, of course, to rupture during another birth. So this one, it could be a candidate for a VBAC. Then we also have our verticals. This is the classic. This is the one we worry about. It is more likely to get a rupture. For that reason, it eliminates VBAC as an option. And also what we would worry about is any type of use on Pitocin on someone who's at risk for a uterine rupture. So that's another thing that has to be considered. Okay, so both of these going down, they increase in risk. And again, the key point I want to mention is finding out how the last birth was cut into the uterus. You just don't look at the scar on the abdomen. So let's check on what we went over. We went over cesareans, we discussed a couple of episiotomies. So we want to know, why is the low transverse uterine incision preferred for a cesarean birth? Well, that's because it's less likely to rupture. Okay, it's a smaller wound. The way it cuts into the way the muscles run, that's why. But some women have to have a vertical delivery or a C-section scar, so you can't always dictate that everyone wants to have a low transverse. There are reasons why they would put in a classic incision, but they won't be able to do a VBAC. So the next thing we're going to ask is, what should a woman who expects a cesarean birth be taught about the operating room and the recovery room? Well, we want her to know her pre-op procedures, that she's going to have a skin prep, an indwelling catheter is going to be put in, what personnel will be in the room, explain to her about how the table's going to be very narrow. She's going to get nervous transferring over to it, but she will have a safety strap. We'll let her know, depending on the situation, her partner can come in. We'll discuss the anesthesia with her, and we'll let her know in the recovery area she's going to have oxygen, we're going to have a pulse ox on her, we're going to have an automatic blood pressure cuff, and that we're going to be assessing her vital signs frequently and checking the fundus, incision, lochia, and make sure she has pain relief. So let's consider this then. How should the nurse modifying the recovery room care of a woman who had a C-section birth compared to one who had a vaginal delivery? Well, remember, they have similar needs. We are going to do the fundus, the lochia assessments. However, additional care, of course, is the respiratory status. We've got to worry about urinary output. Their pain needs are going to be significant after having a C-section. And also any potential complications of anesthesia. So that's why we're going to measure the level of consciousness. And we got to make sure her sensation to her lower legs move. We usually wait quite a bit before they actually get up and get into a shower if they're a C-section compared to a vaginal birth. Plus, again, their diet starts off NPO and they have to be upgraded. Okay, critical thinking exercises. These are going to be similar to your test questions, where I give you a scenario, and based on that, you'll have to answer the next question. So let's go over them. In Chapter 16, it's in a green box. It says critical thinking exercise, and I will read it to you. A physician performs an amniotomy on a laboring woman whose cervix is dilated to 5 centimeters. The amniotic fluid is pale yellow in a moderate in amount, but has a strong odor. So right there, we went over about assessing where we're hoping that it's clear with no odor, and here we have a situation where it's yellow with a strong odor. The baseline fetal heart rate ranges from 155 to 165. Okay. What do we know about that? We know normal's 110 to 160. So that's something we're going to have to watch. But we see A cells when the fetus moves. So at this time, remember, that's the best measure. So despite what's going on, we're getting A cells in this fetus. So that's really good. Maternal vital signs are the temp at 99.7, pulse rate 92, respirations 22, blood pressure 116/80. Now let's look at these contractions. They're moderate to firm. They're going every 3 to 4 minutes with a duration of 50 to 60 seconds. Well, reading that, we understand that it's not more than 90 to 120. And second, if we subtract the 60 from the 3 minutes, she's having a 2-minute interval between the contractions. So she is having a good rest period between those contractions. So let's ask, which of these observations should the nurse regard as normal, which are abnormal? We went over them, right? The situation with her amniotic fluid, we got an odor, we have a change in color. That is not good, okay? We also noticed that the fetal heart rate is slightly elevated. We are going up above 160. Or when we get a range, remember, we never write down fetal heart ranges. So in that question, it may say 155 to 165, but you'll document what's right in the middle of your average, and that would be 160. And 160 is on the borderline of tachycardia. Now, mom's running a low-grade fever, so right there, that dictates to us we're going to monitor her frequently related to infection. We do see a good sign, normal, the A cells. Again, we see a little bit of elevation in some of her vital signs. And from that, what should we do to modify our routine care based on these assessments? Well, one thing is we're going to watch her fever, watch if her fever goes up. We're going to watch if the fetus continues to become increasingly tachycardic. And we will report this to the physician. So those are our normals and abnormals. Let's look at exercise 16.2 in the same chapter. Okay, a woman is having long-term labor induced with oxytocin. Her cervix is 4 centimeters dilated. She's fully effaced, and the fetal head station is at 0. So that's good. Okay. We look at the fetal heart rate. Now she's on an external monitor, and the baseline is 120 to 130. So you will document that as 125 with a variability of 10. Remember what reassuring is, right? Reassuring is moderate variability. That's what we learned in Skills Lab. And moderate is 6 to 25. So if she's varying at 10 beats, that's good. She's moderate variability. That is reassuring. Contractions are firm and occurring every 2 minutes. So every 120 seconds, and they're lasting for 100 seconds. So one of the things you're going to do is let's subtract that 100 from the 120, and that tells us how much of a rest phase she has. So she's only having 20 seconds rest between the contractions. Is that good? No, it's not. So with that, the nurse also notices that it does not fully relax. So what do you think we have? Well, I think what we have is hypertonus in this situation. But at this time, the fetus is not having a non-reassuring strip from it. But remember, one of the things we got to worry about is that although the fetus is tolerating it now, it may not if that continues. So having a contraction pattern like that means we have a non-reassuring situation. So what we're going to do is stop the oxytocin. We are going to bolus her primary line. We're going to turn her to her side, give her O2, then reinterpret after we do all that and see if the contractions are less. And then we will report to the physician what's going on. And he may order, and when we reassess and we see that we're continuing to have the same pattern, because oxytocin is very fast. It has a fast half-life. It's very quick. So usually it's not long when you stop oxytocin that you should see the contraction patterns going a little less if you stopped it for the reason of it being not a good situation, because she's not in the active phase yet. She's just starting She's only 3 to 4 centimeters. Now, if she was 5 to 6 and having really strong contractions, and she kept them, then maybe we won't even restart the Pitocin once we provide the O2 and it got better. But if it got worse and we actually give her a uterus to relax, chances are you're going to knock out that whole contraction pattern that she had. But just because the fetus is healthy, we're going to stop the oxytocin because it's the contractions that are bad. So that's how we're going to interpret that critical thinking exercise, which is right there in Chapter 16. And just so you know, the answer's in the back if you want to go on and review it yourself. Okay, that's the end. Make sure you also review your critical to remembers in this chapter. That is telling you the most important pieces. Also, don't forget to review your drug guide. I didn't go over it word for word, but it is in Chapter 16 on oxytocin. And make sure you do your practice questions.